immediately confirm the findings to the referring team, and this needs a surgical opinion in the first instance, as this patient might need possible surgical management.
So the surgeon wants to know what is the level of obstruction. I haven't from your description where the obstruction is.
Yes. So this looks like a twist within the. So I'm just going to confirm. So I'm just trying to confirm if it's small bowel loops, basically, that's twisting in this patient.
There's a difference between what you're saying and then what you're giving a diagnosis of. You said there's a twisting, but then you're saying there's an intussusception. So there's a huge difference. What exactly is that? Is it an intussusception or is it a twisting? Or do you think they're both the same thing?
No, so there's definitely differences, and this is a case of a midgut sort of twisting of the bowel, which is giving this swirling type appearance, which is centered around the blood vessel here. So that's giving, it's a small bowel twist that's happening. Because the distal bowel is relatively collapsed. So there's this concern for a twisting of the bowel.
Understood. So let's go to the next case. So this patient that I'm going to show you presents with elbow pain.
Okay, so I'm presented with a frontal and lateral projection of the right elbow. I can appreciate that there is a well-defined lytic lesion in the distal humerus. It doesn't appear to have any cortical breach or soft tissue component associated with it. There is some internal ground glass changes going on within the bone, but no cortical expansion. These features, I'm just looking at the lateral projection as well at the same time. It is giving a subarticular appearance in nature. It's an epiphyseal in location. A top differential to consider would be a GCT. Other differentials to consider so the top differential will be a GCT. Other differentials to consider, I can't see septations to consider like a ABC or simple bone cyst. And there's no pathology. Sorry?
Is it expansor?
It's not causing classic expansion of the bone. It's predominantly sort of lytic in nature, and there are some internal sort of changes going on within the bone in sorts of internal lucencies with a very mild sclerotic.
Do you think it's aggressive, non-aggressive?
I think this is, given that there is all the features that's described, it's a narrow zone of transition. I think this is a non-aggressive bone lesion. Can I just ask the age of the patient?
39.
39. So given these findings, this is in keeping with a non-aggressive bone lesion. GCT will be my top differential. I would refer my findings back to the clinical team. This patient will need a orthopedic opinion, and if there is ongoing concern, then a potential MRI can be performed at a later stage.
How late?
If there is no resolution of symptoms, then an MRI can be performed.
Right, let's see if we've got an MR. So let me just share. Okay, hopefully you should be able to see all the different sequences. And let me
yes, see
control. Hang on, where's the control? There you are, you've got the control.
Okay, so I'm just gonna.
So just right click. Just right click.
Yeah.
And scroll. Yeah, there's a scroll option there.
Okay, so I'm presented. This is fluid sensitive, fat suppressed sequence, and on this sequence, I can appreciate marked soft tissue hyperintensity, which is causing cortical, which I can see cortical destruction, with a soft tissue component. Essentially, it's a wide zone of transition. So all the features that I can appreciate with the soft tissue component hyperintensity on the PD fat sequences, I would like to retract my initial statement, and this is in keeping with an aggressive bone lesion. And the differentials for this epiphyseal lesion would be concerning for an osteosarcoma, an Ewing sarcoma. I'd also correlate with patients' inflammatory markers, as I'd consider osteomyelitis within the differential diagnosis too at the same time. This patient needs urgent referral to the sarcoma unit with a view to biopsy.
Okay, we will come back to that. This next patient presents with abdominal pain.
Okay, so I'm presented with patient with abdominal pain. I'm presented with a abdominal radiograph, and I can see both of the pelvis too at the same time. So on the first instance, I can see multiple lines traversing the abdominal radiograph, which are nothing significant. It could be just monitoring bleeds. I'm looking for any dilated small bowel, which I don't appreciate. I can't see any pneumatosis, pneumobilla, or portovenous gas in the upper quadrants. I can see mottled appearance of the bowel on the right side, just represents feces. So looking at the pelvic region to see if there's anything else that I can ascertain. So the sacroiliac joint, looking at the bones now, just to have a quick view. I can't see any missing pedicle. Sacroiliac joints are unremarkable. The film is slightly rotated. It's nothing really striking about this radiograph at this moment.
Okay, that's fine. So what do we do then? Somebody with abdominal pain?
So given these findings, I would.
Well, there's
sorry, I'd just like to just add what.
On the X-ray, you haven't given us any findings. So, but with abdominal pain and a rather unremarkable.
So given these findings, I would refer my findings back to the clinical team and say if there's ongoing abdominal pain, I'd ask for a CT, abdomen and pelvis in the first instance.
Okay, fine. Or you could even do an ultrasound because, we don't know at this point, where is this pain? All I've given you is a history of I just said abdominal pain, could be anything. Clearly, the one thing is obvious that there isn't a small bowel or large bowel obstruction that we can see.
That's correct. Yeah.
So, shall we go through your films?
Yeah.
So, whilst this film is there, let's just look at that. So, what's the most striking thing which stands out about?
I think, is there like a mass lesion in the pelvis? That's the only thing I was just going to add, but I think I was a bit too late to mention something.
No, there isn't. There isn't.
There isn't. Okay.
I can't see a mass lesion, so it's fine.
Okay.
There's no mass. But what is striking about the lucencies that you see? Why are they so geometrical, rectangular in shape? All of them have got exactly the same shape. There is what are they?
Is it packing from sort of drugs and so forth?
That's right. This is a drug mule, and these are drug packets, and you can see these little pellets which are inside, which are actually the drugs. They're exactly the same shape. So the important lesson here is, if the bowel gas lucency does not correspond to a viscous, you've got to explain where it is. There's only a couple of places where it could be. Most of the time, people get caught out if there is peritoneal gas, so that's difficult to pick up. If there is a gas like this, somebody has ingested something, or sometimes people can have tumors which break down and have gas in it. So these are the three places where you will miss out, where you would be easily missing out on films because you don't know where this gas pattern is. So if you can explain the gas pattern, you'd pick up what this thing is. So this is important, because what happens if they rupture?
Can cause peritonitis.
Yeah, he's going to die.
Yeah.
So it's important that you pick it up, because this guy would need CT probably to see how many packets are there. So that's right. So that's the lesson from this. Make sure that you look at the bowel gas pattern, and if the gas pattern is not within the bowel, then you need to come out and tell us where exactly. I think you were. If I tell you this is also another packet, and this is also another packet, and these are little pellets, you'd probably appreciate them now. Initially, this is not like gas. This is more like fecal matter.
Fecal, yeah, that's right, yeah.
This is different. Okay, we go back to the first case, which was this X-ray that I gave you with the trauma history, and there was question about rib fracture. Okay, so important thing is review areas. History is already given, trauma, which means you said all the right things about picking up fractures and pneumothorax. You started with pneumothorax. So sometimes the findings can be subtle. So if you look here, there's a little speck of gas here in the soft tissues. Okay?
Yes. Yeah.
So that's fine. I don't expect you to pick up. But if you look carefully, can you see the visceral line of the pleura? So if you look at the right side, you can see the lung markings going almost to the apex. So here, it stops here, which means with the trauma setting, with a little bit of surgical emphysema, left apical pneumothorax, you said you'd do a CT for a rib fracture. I would say you would have, ideally you should have said, if there is persistent concern, I would do a chest CT because it's a trauma case, not for rib fractures.
Okay.
Stop. And then they would have done a CT because it's a trauma case. They probably would have done it anyways, even if you didn't tell them to do it. So let me give you the CT of this patient, and let me show you the CT of this patient. So there's the CT. I'm just going to go through it. So the first thing that you see the gas lucencies are much more extensive
Prominent, yes.
on CT. And we go to the lung windows. And there comes your pneumothorax.
Thorax, yeah.
So even subtle surgical, if you see a surgical emphysema with trauma, just pick it up and say, even if it's negative, just say, I see something, I'm not sure. It could be a surgical emphysema. I'm looking for pneumothorax. I can't see it, but I would want to do a CT to exclude a pneumothorax in light of the trauma settings. And that's it. You're safe. Even if you don't pick it, it's subtle, I don't care. You're a safe radiologist as far as I'm concerned. But not just because somebody's got a rib fracture and because, we don't even do X-rays for rib fracture.
Yeah,
this is a trauma setting. This is a trauma setting. Okay, the next one was a bit of a palaver because you were confused between intersusception and volvulus. That's what the confusion was. Because you said there's a swirling sign. So this is exactly right. This is the swirling sign in which the mesenteric vessels are swirling. And why they're swirling? Because the bowel is swirling, which means that there is a volvulus of the small bowel. Now remember, mesentery is supplying the small bowel here. So you can see fecal residue in the large gut. Now ideally, you should have gone on to do...
The screen is not being shared.
So sorry. Ideally, you should have gone and done the coronal reformats. That's what you would do in your routine practice, wouldn't you? In your hospital, you were reporting it. So you would have even gone onto the lung windows. Sometimes you're not really sure whether this is small bowel or large bowel. And we use everything we have to tell them whether this is large or small bowel. So this is a volvulus of the small bowel. That's the important thing. Then the surgeons want to know, okay, if you think it's a volvulus of the small and large bowel, where exactly is the volvulus? Is it the upper small bowel, the lower small bowel? So, jejunum, ileum. So these are the things you would normally say, wouldn't you?
Yeah. All right.
So, but you didn't say it. I had to get it out from you.
Yeah.
So these are the things you should be saying yourself rather than me saying that you should have said there's a bit of positive fat in the abdomen. I'm finding it difficult to tell you exactly the level, but my feeling is it's probably proximal small bowel, which is involved because we can see the cecum, the ascending colon, the transverse colon is all full of fecal residue. You could have easily said that the terminal ileum somewhere here looks okay, which means it's got to be somewhere in the jejunum.
Yes.
So these are the things that I would have expected from you. The important thing that you did say was that I'd go onto the lung windows to see if there is free intraperitoneal air. So important thing is it's not an intersusception, it's a volvulus of the small bowel.
Okay.
So remember, why are we doing a CT? We are doing a CT because we want to know the level of obstruction and cause of obstruction. These are the only two things the surgeons are. Everything else they'll find out themselves.
Yeah.
If you can give them some information before they go in as to where is and what is the cause, then it makes a huge difference.
Yes, that makes complete sense.
Next one. So another muddle up on this elbow X-ray. Why was that? This is a straightforward. Well,
yes, it was.
It would have been a straightforward X-ray. It would have been a straightforward MR scan. Had you just taken the time to reflect a little bit on the MR, you just whizzed through the MR. I hardly saw you going through all the sequences. So you went through the X-ray. So there's a lytic lesion, but there's also a bit of elevation of the flat back.
Yeah, I can see it. Yeah.
So that means there's soft tissue swelling. Now, when I give you the MR scan, let's just take one sequence. We'll talk about the other sequence. And you said, ooh, it's destroyed the bone. It's come out. It's aggressive. It's an osteosarcoma. Why did you say that? So why isn't this all synovial thickening centered in the joint? It's intermediate signal intensity. It's on both sides of the joint. It's lining the joint capsule. So this is a synovial-based process, number one. So in other words, it's an intra-articular pathology. It's not a tumor. This is a lytic lesion, as you said, on the X-ray, and this is still the same on the MR scan. There is a well-defined, it's not destroying the bone. You can see the cortex there, but because you were whizzing through it, you're not even interested because you've already made up your mind. This is what I'm going to say, because I can see a soft tissue mass. There isn't a mass, it's synovial thickening, all centered around the joint. So now you've got and this is fluid outside the joint. This is not in the joint. Most of this, so now you're dealing with a synovial-based process inside the joint with a further lucency in the bone. So yes, the only option could be that this is an abscess, but then, and this is an infective arthritis. So you should have said, I think this could be a Brody's abscess with an infective arthritis. Only then I would passed you on this film, not the way that this is osteomyelitis, because there was nothing. Most of this lesion is very well defined. There's not even, I mean, there may be a little bit of marrow edema, but there isn't a huge amount of reactive bone change. So then that makes you the differential. What are the possible joint-related conditions you can think of? Rheumatoid? Yes. Gout? Yes. TB? Yes. So all of this will come in the differential. What would you do? How would you reach the diagnosis? What would you do?
This will need, you need to take a sample of the fluid from the joint.
Correct. There's hardly any fluid. It's more synovium. So what would you do? A
synovial biopsy.
Correct. So you would do synovial biopsy. Of course, you will do all the bloods and everything. And you will discuss the case in the rheumatology MDT.
Yes.
Instead of sending him to a sarcoma center, they'll call you back saying, what the hell are you doing? So this is important. Remember, when you're presented with multiple images, just take a deep breath in, go through sequences. If I feel that you're taking too much of time, I'll say to you, well, I think, why don't you look at this? Why don't you look at that? And then it'll reduce the time. But I completely understand. You're presented with lots of images. It's a bit daunting. So many MR scans suddenly in your face, but that's how you do it. That's how you do it in your department. Okay.
Okay. Thank you.
Good. Well done. So deep breath in, and relax, and just take as you would in your department.
Yeah. Thank you.
Just take it as is. Thank you. So let's go to the third candidate.
Good evening.
Hello. Hello.
Good evening, sir.
Say that again.
Good evening. Can you hear me?
Hello. 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 Good evening. Good evening. So let me show you the first case. So this patient that I'm going to project now has got hip pain, right-sided hip pain.
Okay. So am I audible?
Yes, you are.
Okay. So this is the X-ray pelvis frontal projection of a skeletally mature patient who has presented with pain in right hip joint. Here I can appreciate that the right hip joint space, it appears to be slightly reduced as compared to the left side. I can also appreciate that the bone density, it appears to be preserved. There is no abnormal lytic or sclerotic lesion in the region of right femur, femoral shaft, head and neck. There is no evidence of any cortical breach or any fracture. No destruction, no bony destruction is also evident. Okay, so I am also comparing both the bones side by side. Okay, so I can also appreciate that there is some soft tissue prominence along the right hemipelvis, along the ischiopubic, along the iliopectineal line. Okay, but the underlying bone, it appears to be intact. Rest of the visualized bones of the gluteal region are unremarkable. Bilateral iliac bones are showing no significant abnormality. Bilateral sacroiliac joints are open and patent without any definite erosion. The visualized lower spine is showing some degenerative changes. So I have some owing to the presence of some soft tissue density opacity, which is located along the right hemipelvis, along iliopectineal line, I'm suspecting this could be some infective pathology, or it could be some underlying neoplastic etiology. For further evaluation, I would like to correlate with the clinical history of the patient as well, and I would also go for an MRI.
Right. You're candidate 3, right?
Yes.
So I've given you the control. Can you just point out for the rest of the candidates which soft tissue pathology are you referring? I've given you the control.
Yes, I am suspecting this soft tissue opacity here in the right hemipelvis.
I can't see your.
I can also appreciate that there is. Let me ask for the country. So can you see it now?
Yeah. Okay. Yeah. Okay. Sure.
Okay, so I'm talking about this. This soft tissue opacity here.
Okay, understood. So you would want a CT or an MR?
Sir, I would like to go for an MRI of pelvis.
Fine. Okay, we don't have an MR scan, but we'll come back to this. So the next patient has got abdominal pain.
Okay. So this is the X-ray abdomen frontal projection of a patient who has presented with an abdominal pain. Here I can appreciate that is a very prominent, rather dilated bowel loop, which is located in the mid abdomen, and I can also appreciate that this bowel loop is showing some evidence of thumb printing sign. This could be secondary to any underlying colitis as well. Okay. I can also appreciate that some fecal loaded bowel loops are also seen in the right side of the abdomen as well. Coming toward the left side, I can see that there is some sharp or abrupt cut off in the bowel shadows, due to which I cannot appreciate the prominent bowel shadows in the left hemi-abdomen. Some gas shadows are appreciated in the pelvic region. So coming towards the bilateral sacroiliac joint, I can appreciate that these joints are showing some periarticular sclerosis as well, with an evidence of some nerving. Degenerative changes are seen in the visualized spine. I cannot appreciate any evidence of any pneumoperitoneum or any soft tissue calcification in the visualized radiograph. Okay, so on the basis of these findings, of dilated bowel loops showing some thumb printing sign, and with mild sacroiliitis as well, and there is some colon cut of sign as well. I'm suspecting there could be some inflammatory bowel pathology. That could be inflammatory bowel disease. My other differential would include some ischemic bowel disease, or it could be pseudomembranous colitis. Or next, I would like to, it could be secondary to infective changes as well. I would like to correlate with the clinical history of the patient as well. And I would also like to review the previous imaging as well if the patient has previous images. And next, I would like to go for a contrast enhanced CT abdomen, pelvis to look for the accurate pathology.
IV contrast enhanced CT.
Yes, IV contrast. Yes, CT.
Okay, fine. We will come back to that. So this patient that I'm going to show you has presented with recurrent chest infections.
Okay, so this is the X-ray chest frontal projection of a patient who has presented with recurrent chest infection. So on the first look, I can appreciate that there are some patchy areas of airspace specification in the right lower zone, and these changes are extending up to the right lower margin of the right hilar region as well. I can appreciate that there is some blunting of the right CP angle as well, which could be secondary to any pleural effusion, or it could be secondary to pleural thickening. Coming toward the left side, I can appreciate the left lung, it grossly appears to unremarkable, and left hemidiaphragm and left CP angle is also unremarkable. Bilateral hilar, it looks fine to me. I can also appreciate some reticular shadowing and some airspace specification in the right, mid and low zone as well. There is some reduced intercostal distances in the visualized bilateral upper ribs. Okay, so coming toward the rest of the visualized osseous structures, I can appreciate that there is no evidence of any lytic or sclerotic destructive osseous lesion in the visualized rib, in the visualized rest of the bony thorax, and the mediastinum, it looks fine. I can appreciate that there is some ill-defined some paravertebral opacity on the left side, but I am assuming it would be the shadow of the descending thoracic aorta. The ribs underlying this stretchy opacification is not visualized. So, since this patient has presented with history of recurrent chest infection, my first differential, it would be some infective etiology. May I know the age of this patient, please?
About 88.
It would be, okay, so it would be some infective etiology. It could be either tuberculosis or it could be some viral infections as well. Next, I would like to review the previous imaging of this patient is available. And I would also like to correlate my findings further with CT chest.
So what are the causes of recurrent chest infections?
It would be secondary to the sequestration, previously noted sequestration in the region of lung, which can be a source of the recurrent chest infection. It could be a secondary cause of immunocompromised patient. Patient might be having some any previous disease status due to which is immunocompromised and catch infection repeatedly. It could be secondary to, yes, these are the causes which I can think of right now.
Okay, so you would want to...
I would like to correlate findings with the CT chest.
Okay, let's see if we've got a CT. Right, I'm going to share and then give you the control.
Thank you.
Candidate 3. There you are. You have the control.
So can I scroll the image now?
Yeah. Right click and select scroll. Yeah, there you are.
Okay, so this is the, I have been presented, this is the contrast enhanced CT chest axial view of a patient who has presented with history of recurrent infection. So on the first line, I can appreciate that the esophagus, it appears to be slightly prominent in caliber with an air fluid level. Okay, so there is bilateral pleural effusion as well. Okay, so as I'm scrolling through the images, I can appreciate that the esophagus, it appears to be significantly dilated in caliber, and there is a suggestion of some circumstantial lobulated enhancing wall thickening, which is involving the mid-thoracic esophagus, and it appears to be extending to the gastroesophageal junction, and it also causing some luminal narrowing of the esophageal esophagus as well. This thickening is abutting the mediastinal vessels, but more definite luminal invasion or encasement is observed. I can appreciate that there is some prominent lymph node as well, that is in pre-aortic region, and this thickening is also showing preserved interface with the thoracic aorta as well. Okay, there is no evidence of any intraluminal thrombus in the cardiac chambers. There is bilateral pleural effusion. I would also like to review the lung windows as well to look for any pleural suspicious looking pulmonary nodules as well. Okay, and okay, so on the lung window setting, I can appreciate that there is pleural effusion. There is some patchy ground glass opacities with some interstitial thickening as well. So as I'm scrolling through the images, I cannot appreciate any suspicious looking pulmonary nodule or any large patch of consolidation. There are some ground glass changes here in the lower lobe of the right lung and the middle lobe of the right lung with some touchy areas of ground glass opacification and interstitial thickening. I would also like to review the bone window as well to comment on any lytic cirrhotic lesion which is involving the bone window, which is involving the... Okay. Okay, so on the basis of these findings, on the basis of this circumstantial enhancing esophageal wall thickening, I am suspecting it could be a esophageal neoplastic etiology with a prominent enlarged posterior mediastinal lymph nodes. And there is a bilateral pleural effusion, and these lung findings could explain it would be secondary to aspiration anemia due to the esophagus. Next, I would like to refer this patient to the gastrointestinal entity for further endoscopic biopsy correlation and further workup.
If I was to ask you what's the stage of this tumor, what would you say?
Sorry, sir, I don't remember the stage of the disease right now.
Okay,
I don't remember.
that's fine. That's fine. That's fine. Let's show you one more case. So this is a chest X-ray of a patient who's going to South Africa, and it's a screening X-ray.
Okay, so I have been provided with the X-ray chest frontal projection of a person who has just gone for a screening purpose. Here I can appreciate that bilateral lung fields are unremarkable. I cannot see any focal area of point toleration. Bilateral CP angles are unremarkable. Both hemidiaphragm show no abnormality. At the cardiomediastinal contours, they are unremarkable. I cannot appreciate any paravertebral soft tissue opacity here. Bilateral hilar looks normal to me. Coming toward the lung apices, I cannot see any evidence of pneumothorax or any other pathology. Coming towards the bone, okay, here on the right side, I can appreciate that there is some evidence of double density here on the right side of the cardiac border. So I'm suspecting there must be some right paravertebral soft tissue opacity here, which is lying behind the cardiac shadow. I can also appreciate some opacities in the left retrocardiac region as well. Okay, so coming towards the bone, I can appreciate that there is no evidence of any gross bony destruction or any other destructive bony lesion, and there is no free air under the diaphragm. Okay, so on the basis of this right paravertebral soft tissue opacity and some ill-defined subtle left retrocardiac opacity, I think this needs further evaluation with the CT. I would like to correlate with the clinical history of the patient. I would like to review the previous imaging as well, and next would recommend correlation with CT chest for these findings.
Okay, let's see if we've got a CT chest. I'm going to give you, I'm going to give you the control. There you are.
Okay, so can I scroll the images?
You can.
Okay, thank you. So I have been provided with the scroll the images.
Just right click.
Okay, yes, right. Let me ask the central.
Hang on, let me reshare and give you the control again. Remote candidate 3. Okay, you should be able to.
Okay, yes, now I'm able to scroll the images. So I have been provided with the contrast enhanced CT chest axial view of the same patient. Okay, as I'm scrolling through the images, I can appreciate the upper part of the mediastinum. It looks normal to me, and the visualized regional mediastinal vessels are unremarkable with no evidence of any pulmonary embolism. Okay. So here I can appreciate that along the anterolateral aspect of the heart, I can appreciate that there is some soft tissue density lesion, which is showing marginal hyperdensity. I would like to correlate with the plain CT images as well to see if this is a marginal calcification or if it is this marginal contrast enhancement. And I would, on this scan, I would like to compare it with the density. I would take the house speed unit of this lesion as well. And there is some central hyperdensity as well and some hypodense areas as well. And this lesion is predominantly located in the wall of right atrium. And it is also compressing the right atrium as well, which is this is located in the wall of right ventricle. and it is compressing the right ventricle as well. And anteriorly, it is abutting the posterior margin of the sternum. Otherwise, the interface is intact. Okay, I can appreciate that the rest of the visualized cardiac chambers, these looks fine to me. Okay.
So,
Okay.
what is your differential?
Okay, so I would, okay, so on the basis of this soft tissue mass with marginal hyperdensity, which could be calcification or which could be some contrast enhancement, that would require correlation with the plain X-ray, plain CT, and some enhancing area.
We don't have a plain CT. We don't do a plain CT. So you have to decide on this, what this thing is.
Okay, so my differential on this, on the basis of these findings, my differential would include some benign pathology, which is involving the cardiac muscle, and
like what?
It could be myxoma, but myxoma that usually intra-chamber. These are not located in the wall. Sorry that I'm unable to think of any differentials regarding this pathology.
What do we do? I mean, now you need to either clear the patient or not clear the patient.
I would recommend some tissue sampling of this pathology.
What, stick a needle in?
Sorry?
You're saying you're going to stick a needle into the heart?
No.
Because you're saying it's coming from the wall of the right ventricle, right?
Yes, it's coming from the wall of the right ventricle, and it is somehow okay. So this lesion is also extending up to the. This lesion is also extending inferiorly to.
Okay, so if it's not in the wall of the right ventricle, where do you think it could be?
It could be. I think it could be. It could be in the pericardium.
Could be in the pericardium. So what could be in the pericardium, which is calcified?
In the pericardium. So it could be secondary to. It could be calcified pericardial effusion secondary to the previous history of any infection, like tuberculosis, or it could be any viral infection. It could be some localized calcified collection as well, or it would be some calcified hematoma pericardial due to previous history of any cardiac tamponade. But these all findings require correlation with the prior imaging as well as the clinical history of the patient as well.
The poor patient doesn't know anything about this. He's got no history.
So my two differentials, it could be calcified hematoma, or it would be calcified pericardial fluid.
So shall we allow him to go to South Africa or not?
Or it would be no, sir. I don't think that this person should go to South Africa unless and until his further workup is not completely done.
Okay, let's go through your films. So I had to push you a lot to get you out of the ventricle into the fact that there is something called pericardium around the heart. And if you look, all of this calcification, even going onto the left side, you don't have to do a non-contrast CT to find out if something is calcified or not. All you have to do is change the windows. So you can see the difference between the contrast and the calcification. Can you?
Yes, I can see it now.
So this is all calcified pericardium with a large pericardial cyst which is indenting the right ventricle. Okay. Now, if the cyst has been there for a long time, the central density can change. It can become more dense over a period of time. So then the differential is what are the causes of pericardial calcification? And you've mentioned viral pericarditis, you've mentioned TB. So when you mention the word TB, the question then comes, can this patient travel or not? Because that's why we're doing the X-ray in the first instance. Yes. Why do you think we're doing the X-ray? We're doing the X-ray, we want to know if there's somebody's got TB or not. Yes. So then you should have gone on to the lung windows to see if there's any active TB or not, because remember this calcified, even if somebody's got calcified tuberculous pericarditis, that means it's long-standing. That means it's not active. So the only way in which you can tell somebody's got active disease is to look at the lung windows to see if there's any tree and bud nodules in the lung parenchyma.
Right.
So you should have mentioned it at least. I know you didn't do it at all, but you should have said in your description, I would like to look at the lung windows to see if there's any pathology in the lung, which you didn't. If there wasn't anything, I would have said there's nothing there. So that's right. So important thing is the X-ray, you did well to pick up the fact that there was a density on the right side of the, so I'm just going to bring up the X-ray again. So I think you picked up on this, but if you look carefully, you can see a curvilinear calcification going all the way up to here. So all of this is the calcification. So you did well to pick it up, because if you'd not picked it up, I wouldn't have given you a CT. So you only get a CT if there is a valid reason for a CT, which is fine, because that there was something in the retrocardiac region. So that's why we gave you the CT. So remember, review it is really important. Pick up the findings and then look at what's going on. So discussion is going to go down that route. Is it in the heart? Is it in the pericardium? If it's in the pericardium, what are the causes of calcification? And that's how the viva will go.
Right. Thank you.
Okay, so the next thing that we showed you was the X-ray, in which actually I've already given you the clinical information, which is quite obvious that the patient has got recurrent chest infections, right? So if somebody is immunocompromised, why would they get it in the right lung base? It's typical of aspiration. Right lung, right lower lobe, typical, and that's why they're getting recurrent chest infections, because they're aspirating. Okay, fine, I give you that this could be the descending thoracic aorta. That's fine, but there is definitely a bulge here that you need to account for. So if somebody's got recurrent chest infection, you need to find out why, and that's why you have to have a CT. And when we gave you the CT, the discussion is going to be, because it's very obvious on CT that this patient has got an esophageal cancer, the discussion is going to be on the staging of esophageal cancer, because everybody will pick up consolidation on the chest X-ray. Everybody will say, I want a CT. So how do we differentiate candidates from each other? We differentiate them on the staging of the esophageal cancer. I haven't even asked you a single question about staging. All I asked you was, what stage do you think this is? And actually this, you could have easily said this is stage 4, but you didn't bother to complete the whole scan, because this patient has got bilateral adrenal metastases here. Can you see that?
Right. Yes.
There's a big mass there, there's a big mass here. Now pleural effusion could be stage 4, but you have to aspirate to demonstrate malignant cells before you can say that. I would have then gone down and asked you, what are the criteria for resection, irresectability? What is the circumference of the aorta involved? So all of that discussion comes in, but you've already said, I don't know the staging. There's no point in me asking you, because you've already said, I don't know the staging of esophageal cancer. You should know the staging of esophageal cancer. You should know the staging of lung cancer. You should know the staging of prostate cancer, pancreatic cancer, gynae. So all of these questions are going to come to you in the exam. Okay, so the other thing that I showed you that you picked up, but I still am skeptical, because you never mentioned the most important word in this film. You said there's a dilatation of the colon, there's some thumb printing, and then you started giving me the differential of ischemic colitis, inflammatory bowel disease. You said this patient has got sacroiliitis. He hasn't got sacroiliitis. The important thing is, did you use the word toxic megacolon, or did I miss it?
No, I haven't used it.
So if you don't use toxic megacolon, you failed this film.
Right.
Because this is the important reason why this film is there. Dilatation of the small, large gut, dilatation of the transverse colon with thumb printing. What is the next thing you should be saying? Toxic megacolon.
Toxic megacolon.
That's right, because this is an impending perforation. And if you do not mention it, you're not going to pass on this film. I'm not interested in the differential of ischemic colitis and inflammatory bowel disease. What I am interested is do you think how serious this condition is?
Right.
So this is just like tension pneumothorax in your chest. You've got to pick it up, and you just can't get away by saying, oh, this is a pneumothorax, because you won't pass if you just said it was a pneumothorax and didn't say there was a tension pneumothorax. Similarly, just saying that there's a dilatation of the large gut with thumb printing, you've got to say this is toxic megacolon. I'm concerned that there's an impending perforation. I would like to do a CT. I will involve the surgeon immediately There may well already have been a perforation that you're not seeing on the plain X-ray.
Right.
So this is a pass or fail film.
Right.
Really important. And then I gave you this pelvis, which which you did well to pick up the soft tissue mass on the right side, but you didn't mention the other bits. So the other bits is, if you look at the iliopectineal line here and the teardrop, can you see that on this side?
No.
No, you can't.
No.
There's no iliopectineal line. There's no teardrop because there's a big lytic lesion which has destroyed the bone.
Okay.
And what you're seeing is the extraosseous bit of that lesion. So, but I'd still pass you because you said there was an extraosseous, you said there was a soft tissue mass, and I would like to do a CT or an MR scan. Now, of course, if we were to do a CT or an MR scan, you'll pick it up.
Right.
You'll find out that there is a destructive bone lesion there, and then you could, decide, discuss, do a biopsy, find out any other lesions. What are the causes? Are there mets? Is this a solitary lesion? So all that discussion comes in.
Right.
Okay.
Yes.
So important thing is, in pelvis, never miss iliopectineal line destruction and
Right.
teardrop. Good. Okay, last
Thank you.
candidate,
Thank you.
number 4.
Yes, doctor, I'm here.
Very good. Let's have a look. See what we're going to show you. Okay. So this is a patient who presents with breathlessness.
Okay. So I'm presented with a frontal radiograph of the chest and skeletal material patient presenting with a history of breathlessness. I'm going to go systematically through my review areas. I can appreciate that there is within the right middle lung zone and perihilar region, there's evidence of ill-defined opacity and haziness that's projected over this lung region. I can also appreciate that there's the right hilum. I can appreciate there's a density projected over the right hilum as well. And I can see that there's also, I'm now looking at the mediastinum and the cardiac contours. I can see that there's opacity. It's a dense opacity that's projected over the lower aspect of the within the midline over the cardiac shadow. I'm now looking at the left hilum. The left hilum appears rather unremarkable and its normal location. I can see that there appears to be slight reduction in both lower lung volumes, but I'm not sure if this could be attributed to the fact that the patient hasn't maybe taken a proper inspiration. And I can also appreciate there's also some particular nodular opacities over the left lower lung zone as well, with some cystic lucencies or ring-like lucencies that could denote the presence of maybe bronchiectasis. And there's also a curvilinear shadow within the left, projected over the left border of the heart. It can be hilar as well. So when a patient presenting with breathlessness, I can, and with bilateral mid to lower lung zones, particular nodular opacities, and maybe ring-like shadows that could denote bronchiectasis, I would consider an underlying fibrotic lung disease. I can also appreciate that the upper lung fields appear to be spared. Now I'm going to look at the rest of the X-ray. I can see that the trachea is central in position, and I can see that there's no evidence of pneumothorax, and the costophrenic angles are free, and I can appreciate that both hemidiaphragms are well delineated. Now I'm going to look at the bones. In my routine practice, I usually zoom in to make sure to look carefully for any lytic or sclerotic lesions within the ribs. And I can't really examine the lower ribs properly in this patient.
Fine, the ribs look fine.
And so there's no abnormal bony changes. So to take this further, I'll look at previous, I can bring my findings to referring clinical physician. I'll try to correlate with the patient's clinical history and look at previous imaging if available. And if not, I would take it further by me suggesting or recommending a CT test for further characterization of the underlying lung pathology.
What sort of CT would you want? What sort of CT chest?
What sort of CT chest?
Would you want to do an HRCT? Would you want to do a conventional CT with contrast?
I would prefer, if the patient is available within the radiology department, I would...
The patient is never available within the radiology department. You have to recommend something, and then they'll come back.
Well, given now that I'm looking closely, I can see that the aortic knuckle in this patient is rather prominent with slight deviation of the trachea. So, and if this patient is elderly, I would recommend, I would correlate, of course, with the patient's kidney function test. And if possible, I'd suggest a contrast enhanced just to also look at the patient's vasculature. But normally I'd recommend a contrast enhanced CT if I suspect there may be an underlying
So just in one line, what is your working diagnosis at this stage?
In one line,
I don't know what exactly is the working diagnosis at this stage.
At this stage, I would consider, given that the patient has a history of breathlessness, I would consider in the reticulonodular opacities and ring-like shadows that are prominent within the left mid-lung zone. And also the shaggy...
No, not the description again, okay. Just the diagnosis.
I would consider maybe a fibrotic lung disease or interstitial...
Fibrotic lung disease, okay. Fine, that's all I want.
Okay.
That's all I want to know. Okay, let's go to the next X-ray of this next patient. So he is a 69-year-old, presents with abdominal pain.
Now I'm presented with the frontal abdominal and pelvic radiograph. I have a 69-year-old male presenting with abdominal pain. I'm going to systematically go through my checklist. I can see that there are dilated bowel loops located within the right aspect of the mid to lower abdomen within the region of the iliac fossa. I believe that they are small bowel in nature and appear to be prominent and dilated. I can also appreciate that there's an abnormal radiolucency that's projected over the region of the left hypochondrium in the left lumbar region. And I can make out both those shadows. The left cell shadow appears to be slightly bulky, and I can see there's an abnormal calcification that's projected over the upper aspect of the dorsal vertebra or the dorsal spine. It's rather smooth, but given that it's very opaque, I would consider it could be calcifications related to the maybe the aortic vasculature. I can't really appreciate any lucencies projected over the right hypochondrium, and that could denote, for instance, the presence of portal venous gas or any branching linear lucencies over this area that could denote pneumobilia. There are no other abnormal calcifications I can appreciate within this radiograph. I can't really make out the sacroiliac joints in this particular view, but I believe they may be unremarkable. But given that this man is presenting in an acute clinical setting with abdominal pain, and I can appreciate their dilated bowel loops, and I cannot really make out if there's pneumoperitoneum. There's no... I can't really appreciate a Wriggler's sign or any abnormal triangular lucencies of air, but given the patient's age and the presence of bowel dilatation, I would of course, have to consider the possibility of bowel obstruction. Normally, I would look at the rest of the radiograph if there's any abnormal air lucencies projected over the region of the inguinal orifices below the level of the inguinal orifices. I would consider maybe a hernia, but this is not. I can't really make it out because it appears to be zoomed in. So I would proceed with convey these findings to the referring clinical physician and correlate with the patient's rest of the patient's clinical data, and recommend that the patient undergoes a CT of the abdomen and pelvis with intravenous contrast for better detection.
Okay, let's see if we've got a CT for this patient. I'm just going to share it and give you the control. You are number 4. There you are. You've got the control.
Mm-hmm. Can I scroll with my mouse, or do I?
Right click on your mouse, and yeah, there you are. No, right click.
Right click. Okay.
Scroll. Select the scroll button.
Okay. Okay.
Let me go back to the original window. Let me just reset the windows for you. There you are. Now you should be able to scroll.
Okay. So I'm just gonna make sure that I'm starting from the last cut. Okay, I'm gonna start from the last cut and go slowly upwards. So first, I don't see anything, any bowel loops projected over the inguinal orifices. I'm just following right now on the rectum. I'll just scroll first through the images before reviewing my findings. Okay. Okay, now I reached the. Okay, so the first thing that came to my attention is that there appears to be a large dilated bowel loop. Isolated bowel loop, I believe, that's present in the upper to mid-abdomen. And I can see, just 1 minute, I'd like to go back up. See if, I'm just having, I want to see if it's related to the stomach. I can see that there's a nasogastric tube within the stomach, and this lesion is closely related to the stomach, almost as if it's arising from it. And you can see that it can, okay, I'm just trying to now, I can see that it's compressing. So okay, so this lesion is arising from the stomach, and it's the rest of the small bowel appears to be collapsed and unremarkable, and the large bowels appears to be collapsed and unremarkable. So, and I can see that this lesion appears to be, it's continuous with the stomach lumen, and it contains foci of air, and now I'm gonna go and look at the rest of the solid organs. I can see there are multiple focal, hepatic focal lesions that are hypoattenuated. I'm just having trouble controlling the scroll. They're scattered throughout both lobes of the liver, and they're hypodense and thin-walled. I would consider maybe the possibility of hepatic cysts, but I would correlate with ultrasound. The spleen and the kidneys appear unremarkable. Now I'm going to look closely at the adrenal glands, and they also appear unremarkable. And I'm just going to quickly look at the patency of the vessels, and I can see that they are patent. So I can see that there's an abnormal dilatation, or there's like an abnormal cystic collection that appears to be continuous with the stomach in this patient. And given the acute presentation, I would consider a gastric volvulus, because I can see that it continues with the stomach, and even the peripheral enhancing wall is also similar to the rest of the gastric mucosa. And
okay, so what would you do?
I would I would consider this as an emergency and immediately convey my findings to a referring clinical physician for immediate gastric compression, decompression, or surgery. But I can see it, and I would also look for any signs of perforation and switch to the lung window to see if there's any free air. I can see that the mucosa is still well enhancing, so till now I can't really make out if there's any ischemia or gangrene, but this is considered as something that would require immediate attention, and also refer the patient to on-call surgery if necessary.
Okay, thank you. Let me take the control. Stop scrolling now. Okay, let's go to the next patient. So this patient presents with fever, cough, and is unwell.
Mm-hmm. So I presented with a frontal radiograph of the chest and a skeletal mature patient presenting with fever, cough, and is generally unwell. So in the first instance, I'm just going to look at the radiograph before starting to convey my findings. Within the first instance, I can appreciate that there is an area of right paravertebral thickening, right paratracheal thickening, that appears to be of opacity. Now I'm going to look at both hyala. Both hyala appear unremarkable, and they're normal in location. I don't see any lobulated lymphadenopathy. I can appreciate that that there's a hazy area, there's hazy ill-defined opacity that's projected over the region of the left lung lobe, and it doesn't appear to be obscuring the left heart border. And I can also appreciate that the visualized parts of both costophrenic angles are free, and there's some linear bands that are related to within the left lung lobe that are related to the hemidiaphragm. The trachea appears to be central, and the mediastinum and the cardiac contour appear to be within normal limits. I can't appreciate any retrocardiac opacities. And now I'm going to look at the bones and to see if there's any lytic or sclerotic lesions that are related to the bones, and I can't appreciate any definite bony abnormality. I can appreciate that both hemidiaphragms are well delineated. So given that the patient is presenting with a history of fever and cough and generally unwell, I'd consider an underlying infective etiology. And
whereabouts is the infection? Sorry.
Given that the patient is presenting with fever and cough and is generally unwell, I would consider underlying infective etiology.
Yes, so which bit of the lung is what I want to know?
The bit of the lung that's involved. I would I can see that there is an ill-defined opacity or haziness that's over the left lower lung region. However, the left upper to mid lung zones appear to be they don't show any nodules or opacities, and the right lung zone also appears to be rather unremarkable, apart from just an area of also an area ill-defined opacity I can appreciate here, but it's more prominent on the left. And
okay, so what do we do?
So it'll depend if this patient is presenting with with abnormal inflammatory markers, elevated inflammatory markers, and fever.
Yeah, I mean, there are inflammatory markers are unwell, they're raised, CRP is raised, the patient is unwell, running fever. What would you do?
So I would, one of the patient is an immunocompromised, and if I would consider a mnemonic process, and I would convey these findings to referring clinical physician, and I'd also recommend that the patient gets a follow-up X-ray of the chest.
How long?
After a period of 6 weeks.
6 weeks, okay, fine. Okay, we'll show you one more case, which is this patient. He's 68 years of age and presents with non-specific pain.
Okay, I'm presented with the frontal radiograph of the abdomen and pelvis in a 68-year-old male patient presenting with back pain. So within the first instance, I can see that both sacroiliac joints appear to be sclerosed and fused, and I can also appreciate that there is there's a linear opacity that's following through the vertebral column, which is characteristic of the dagger sign, which is seen in patients with ankylosing spondylitis. So I would assume that, given the patient's age, and I would assume that this patient has ankylosing.
Any other signs of ankylosing spondylitis that you can see?
In this patient, I would like to look at any other signs of ankylosing spondylitis. Usually in such patients presented with pain, I would be concerned for a fracture. So I would look closely at the pedicles and the vertebral body heights to make sure.
That's fine. So let's go through your films. So sometimes you'll be given one film like this, which is quite straightforward, which is the patient has got quite a few signs of ankylosing spondylitis. This is classical bamboo signs. So you can see the syndesmophytes, which are fusing the whole spine. Of course, the spinous processes are fused as well, bilateral sacroiliitis, osteitis pubis, enthesopathy at the insertion of the greater trochanter. You can see calcification there. And this is enthesopathy at the greater. So it's got all the hallmarks of ankylosing spondylitis. And then in your routine practice, you'd say, I'm looking for complications of ankylosing spondylitis, which could be fractures in the spine. And so that's a straightforward viva to start the film. So hopefully the film will come off and they'll go to the next case. So clearly you picked up, that's absolutely fine, you picked up two signs, but there are other signs as well on this film. And you said the right thing when you said that there could be a fracture of the spine. Let's go to the next one. Now, what I want you to do in your viva, can you see the film, by the way?
Yes, doctor.
So is to finish the film. You just keep lingering on and on and on, and then you have to stop somewhere and give your differential or give your opinion as to what's wrong with the patient. So not every patient you'll have to go to CRP and blood films and talk to the physician. You have to give an opinion first. That's what happens in your department. You first give your opinion before you start looking for bloods and stuff like that. You hardly ever get bloods in your department. You never know what's going on with the patient. But you have to give an opinion as to what is wrong with this patient before you ask for all the other things. So here you started this film with saying that there was some increased opacification in the right paratracheal region. Then you went on to the atelectatic bands. And then right at the end, you said there was some infection, which I had no idea where the infection was because I had to ask you twice, where do you think in the lung is the infection? And then you started describing the upper zones are clear, which means that it's not there. Middle zones, you couldn't see anything. And then you ultimately ended up with something in the left lower lobe as the possible site. And you send the patient off for 6 weeks. gets another X-ray in 6 weeks. What do you think will happen to the patient in 6 weeks? Probably be dead because of septicemia. Because what you started was there's abnormal paratracheal soft tissue thickening. Why didn't you take it forward? If somebody's got paratracheal thickening, that normally the paratracheal stripe is 1 to 2 millimeters in thickness. This is about a centimeter in thickness, right? Maybe even 2 centimeters from hair to hair. Would you let it go?
No.
No. So why would you let it go? What are you worried about?
I'd be worried for a right paratracheal mass lesion or
So what would you want to do?
I want to do CT chest with intravenous contrast.
So you would want a CT chest. Here comes the CT chest. Can you see the CT chest?
Yes.
So what's going on here? There's a big mass sitting here with a necrotic area of breakdown. So I'm just scrolling through it so you can see it. But the important thing is, so what's the differential?
The differential, it could be it could be it's a necrotic mass. I would consider a differential diagnosis for superior mediastinal mass, such as
What was the history? The patient was unwell, was running fever and cough.
it could be an abscess.
Could be an abscess, and you can see that there is a necrotic cavity with a central air lucency, possibly some fluid, who knows. But then what is this?
It can be an esophageal, I can see it could be a fistula.
That's a perforation of a foreign body. So you can see there is a perforation, this foreign body is coming out and forming a paramediastinal abscess. So you see, the critical thing is you would not even come to a CT because you never mentioned anything. You just gave a passing reference to a paratracheal stripe thickening and then moved on. And at the end, you never ever said to me, I'm worried about that paratracheal stripe, I would want to do a CT. So you won't get a CT in the exam. You'll only get a CT if there is a good reason that you've given me. And you didn't give me a good reason. All you said was that there's infection, and I look at the inflammatory markers and I look at the CRP and send the patient off, come back in 6 weeks. So important thing is it's a very important review area. Paratracheal stripe should not be more than 1 to 2 millimeters thick. If you think it's more thickened than 1 to 2 millimeter, you need to investigate it.
Yes. I noticed, but I didn't pick up on it. Yeah, I didn't take it further.
So that's critical because this patient is dead because of not picking up and investigating it further. Because what happens if you don't resolve this? The patient will get septicemia. There's already got a big abscess. You need to drain this. This abscess needs to be taken out, should be put on antibiotics. But the important thing is, unless you take the foreign body out, the abscess will remain there. So all of that conversation would have happened only if you'd picked up on the paratracheal stripe and taken that CT, because then this conversation would have happened. Okay, the next patient was this. So remember the second candidate when I was telling you that there could be gas lucencies which you can't account for in the tummy. This is one of that examples. So here there is a big lucency that you did mention, that there was a lucency in the left upper quadrant, which actually you can't put in any one organ. It's not in the gut, it's not in the peritoneum, it's not exactly stomach. So what is it? Because the shape is pretty abnormal, it's quite extensive. But you said there was small bowel dilatation, and I'd like to do a CT, which is fine because you suspect small bowel obstruction. So we gave you the CT, and then you picked up on this thing immediately, which is good. But what is the important thing? This patient has got a big mass sitting next to the stomach or arising from the stomach. You can see the NG tube. You can see it here. You can see the NG tube tip coming down. So there's the NG tube tip. So then the question is, what is this mass? Is it a volvulus? If it is a volvulus, then why is the esophagus not dilated? probably because you put an NG tube, but more importantly, if you see a large mass arising from or closely associated with the stomach, you have to think of GIST. So this mass, GISTs are solid tumors, they're locally aggressive, so they will invade the wall of the stomach. The important thing is look at the fat planes around it, they're nice and clean. So it's not an abscess. However, because it's broken through the wall of the stomach here, there's a big gap. That's why the fluid and air has gone into the mass, because it's eroded the wall of the stomach. So that's why this mass looks so abnormal, containing gas lucencies, because of the erosion and all the fluid and the air getting into the mass. That's why it looks like that. But otherwise, there's nothing else to suggest that this is something sinister, because the fat planes are absolutely pristine, the margins are very well defined. So this is a GIST, big mass adjacent to the stomach. Always think of GIST. Adenocarcinomas and tumors of the stomach tend to infiltrate into the wall of the stomach. They don't tend to produce masses outside or adjacent to it. And you're right, you would have done an ultrasound to confirm that these were just benign looking simple cysts. Okay. So you still would have probably passed because the discussion was reasonable. Then I showed you a chest X-ray, which again, there was lots of toing and froing and lots of discussions. When I said, what is your principal diagnosis? Again, there was another long rant about the reticulonodular opacities in the lower lobes, and this could be an interstitial-based process. Then finally I had to ask you again, what is wrong with the patient? And you said interstitial lung disease. So you need to come out with your opinion. You don't want to drag the film out too long. You've been giving me the information already. I'm listening to the information. And when I ask you, what do you think is the diagnosis? Then you give me the diagnosis. I think this is wrong with the patient. So lots of findings as you picked up, but you didn't actually pick up the findings that mattered. So what are the findings that matter here? So the first thing is, okay, fine. There may be a little bit of interstitial lung shadowing. That's fine. Maybe a little bit of radicularity. You said you did mention this, that there was some calcification in the left side, which was there. You did mention something about a retrocardiac calcification, because I remember you mentioned something about this, but did you see this? Did you see this? So these are densities, and did you see, you said you said the upper zones are relatively spared, but they're not actually. Can you see that? So what's going on here? These are dense branching opacities. This is curvilinear opacification. What's this? They're in line with the thoracic spine. See? So these are vertebroplasties. Can you see that? And what happens when somebody has a vertebroplasty? They can produce emboli called cement embolism. Have you heard of that?
Yes.
Remember, there's the Bateson's venous plexus in the spine. So when you stick cement into the spine, some of the cement gets into the vein, and where does it go? It comes to the lung and produces emboli. So it produces cement embolism. So this is what a cement embolism would look like. Curvilinear branching opacity, plugging the vessel, and you can see how cement has gone into the peripheral vessels. So this is a classic appearance of cement embolization. So cement embolization is not dangerous in the sense that whenever you do vertebroplasty, you'll always see a few little dense vessels because some of the cement gets into the lung. But if it gets a big plug into the main vessel, then that can be a problem, as in this case, because there's a big cement here dividing into the main vessel because the main vessels are running here. So this is classical vertebroplasty complication, which is cement embolization. If you haven't seen it, you can see it now, and you can remember it because it's a diagnostic film. Okay.
Okay, thank you,
with
Doctor.
us?
Yes,
Thank you very much.
Thank you.
So I think that's pretty much it, really. Lots of films. Remember, I've tried to show you mostly plain films, mostly. I could have shown you lots of MR scans. I could have shown you other things, but I've tried to give you a flavor. Plain X-rays is where you will falter still. So important thing is take it forward one step, and if somebody gives you another investigation, you decide what you can do with the investigation depending on, as you've done today, picked up the findings, given a differential, said I would like to refer to the physician. But don't say that in every patient. You have to refer to the clinicians where it is required. Just don't come out as a standard thing that I'll look at the bloods, I'll look at the, yes, you do say that, but not in every case. You say that when it's required. But I think overall it's been good. Most of you do know all of your subject. It's just a matter of polishing a few things here and there. Is that okay? Admin, I think we'll call it a day now.
It's fine. Thank you very much.
Thank you so much.